I think we're ready.
All right, I will let everybody in.
All right. All right, we got everybody in? Maddie, you can hear me? Perfect. All right, well, welcome everybody. I want to, formally welcome everyone to 2020's Straight Talk for Emergency Medicine Reimbursement Issues. This is our 29th time giving this conference, and I can, certainly say that we probably have never had a conference quite like this, as I'm sure there's a lot of things this year that we've never really quite done, quite like we've done this year. So just want to thank everybody for attending and really highlight the importance of, this conference and what we're going to be doing. To get into things, certainly there's been a number of challenges this year. Certainly the COVID-19 pandemic being, front and center, some of the issues that we've been facing, but on the other side of things too, we've been dealing with a number of reimbursement issues, both, locally in Michigan and national as well. In the end of the fall, we've, recently in the state of Michigan passed balanced billing legislation, which tied reimbursement for out-of-network providers to 150% of Medicare. And then when we couple that with the fact that Medicare is actually cutting their fee scheduling, we realize that as part of, running emergency centers and keeping things financially viable, we're going to continue to be asked to do more with less. And this is something that we're going to continue to, fight for and to, work for to try to create a fair environment for all of our emergency physicians, nurses, techs, and patients to be able to experience while receiving care. In addition to that, with the COVID-19 pandemic, we've also seen a decrease in our number of emergency visits pretty much across the entire United States. So these are just more challenges that we've really faced. So this has been a time, where emergency medicine has really felt, a new challenge. But it's not all doom and gloom. Starting in March when the pandemic really started to take hold within the United States, I can say, with full, heart here that, emergency medicine stepped up to the front line. When this was something where we had very little information on what exactly this was, how dangerous it was, what we needed, emergency medicine ran to the very front of the battle, and we've been fighting there ever since. And I think that fills certainly all of us with a sense of pride that, we're part of this community, and, we run, when there's a fight, we run straight forward to the front of the fight. So I think that just highlights how important it is that we make sure that we're able to, adequately keep ourselves financially viable. Because when the next pandemic hits or the next, great emergency hits, we need to make sure that our emergency rooms are staffed with highly qualified individuals, that they have the financial support that they need to be able to get the right personnel, the right equipment, and have the right experience that we can continue to run toward that front line. I also want to take a time here to thank our Straight Talk sponsors. We're going to have a little video that's going to be coming up from our Platinum and Gold sponsors. I also want to encourage everybody that at 9:30, we're going to be going into some breakout sessions so that you take that opportunity. We have 30 minutes that you can attend the different breakout sessions and spend some time with our sponsors. Without our sponsors, we don't have the ability to, put on such a conference. So we're really appreciative of all their support that they've given us, over the years, and their continued support that they're going to have in the future. All right, so Maddie, I'm going to stop sharing. We'll get to those videos and then we'll kick it back.
All right.
Our industry is changing. The rise in high-deductible health plans has shifted the collection risk to medical providers and made patients the fastest-growing payer. The business of healthcare has become a costly endeavor, but with the right partner and the right technology, the financial side of your business is taken care of, so you can take care of your patients. That's where Zotech Partners comes in. We're an authority in revenue cycle management and patient engagement for healthcare organizations. Getting claims paid quickly and appropriately is what we do, made possible with our industry-leading service team, unique processes, and fully integrated proprietary technology. Automation is at the heart of our direct-to-carrier claims filing and denial management with charge capture technology, so we can deliver accurate payments with rapid turnaround times for providers. Our extensive and proven patient experience model automates the process from registration to account resolution with mobile billing, so providers can effectively collect money from patients while meeting them where they are. Then we bring it all together with intuitive reporting and analytics technology to help providers understand and apply their data. And with compliance and SOC 1, SOC 2, and PCI DSS certification, providers and their patients can rest easy knowing that all levels of their organizational and data security are covered in every step of the revenue cycle. Bottom line, Zotech has helped hundreds of medical groups and healthcare organizations generate significant ROI with actionable results, removing the financial burden so they can focus on patient care. Think differently about the healthcare financial experience. Talk with a Zotech team member today.
All right, thank you, Maddie. So just a couple of quick bookkeeping things before we get started here. Just for everybody, if you're signed in, can you please make sure that you have your full name listed within the Zoom, so that way we can make sure that everybody gets their recognition for CME purposes. If you're calling in by phone, please just send a quick email to our MSEP staff with your name and your phone number, and that way we can make sure that we get your CME completed. Next, during our presentations, If you could please use the chat window for any questions that you have. Once the presenter has finished their slides, we're going to go through those questions, and we can ask our presenters that at that time. And for whatever time that we have remaining, we'll be able to perform some discussion. We also have time at 11 a.m. today for an open Q&A. So if another question comes up later, you can always save it for them as well. All right, with that being said, we're going to get into our first lecture here. This is going to be with Dr. Mike Gronowski and David McKenzie on 2021 ED reimbursement trends.
Just a quick AV check before we get started. Hopefully everyone is viewing the title slide, 2021 reimbursement update and national trends. And 29 years of this conference going on. Hopefully year 30 will all be in person. I think nothing would make any of us happier. And I think Michael really set a terrific tone describing that we have become the front line as well as the safety net. We've been the safety net all along, and now we're really the front line. The front line is held. I guarantee that in this audience, there is not one ED represented where every ED shift wasn't filled and all patients were cared for. We literally have never given up. And we've had colleagues get sick. We've had colleagues suffer mental health crises, and we've even had colleagues pass away. But the front line is held. And we are now moving into, on one hand, a darker period with rising cases. On the other hand, many of us have started getting immunized now as the very beginning of what sort of feels like our fight back. And we have some therapeutics as well. And many of us have started to administer those successfully in our emergency department. So one of the things that we face is a decrease in volume, which Michael mentioned. And I think it's helpful for folks to have some benchmarks. So looking at a sample of a little over 400 national EDs, the ED maximal volume decrease was 48% during March and April compared to a pre-COVID January baseline. And that volume has now come back. We're down about 20% on a site-to-site variation basis from that January 2020 pre-COVID baseline. But now we're 8 months into this, so we have lots and lots of data. So it makes a little bit more sense now to benchmark year over year, compare 1 month of 2020, for instance, October of 2020 to October of 2019. Well, using that comparison, we're down about 16%. We'll look into which patients are staying home. Urgent cares have really suffered. Maximum decrease was down 76%. Many of them simply closed. There's been some return towards normal. They're now down still 43%, and even year over year, down 27%. PEDS ED volume has been the most significant change. We're going to have to come up with, and I've got some thoughts about how to provide services to those patients in the post-COVID world. PEDS ED volume was down 70% at the maximum. It's still down 52% compared to the pre-COVID baseline, and year over year, still down 38%. Now, those sites that have initiated testing and reached out to their communities to provide that service have actually seen their volumes go up, at times above their pre-COVID baseline. That could be an ED visit, could be an urgent care, could be manning a tent or a parking lot. But that's a very effective way to provide a service to your community. Now, what about the trend of COVID-related ED visits? And this sort of mirrors the case counts, the hospitalization, and sadly, the mortality counts as well. So April, May, 25 to 30% of ED visits nationwide related to COVID. This is the beginning of the scourge. June, things sort of dip back down a little bit. July, back up. But I think importantly, if you look at the bottom portion of the slide, we've got a steady march up. And these patients are higher acuity and require more resources. So this information is presented to try and start to inform a discussion surrounding staffing. 15 to 19% of patients related to COVID in the month of September, then 19 to 24%, 22 to 29% in November, and early December data shows we will have a 3 handle. In some EDs, approaching a third of patients will have COVID-related diagnoses and needs. Now, who is staying home? If you look at the left side of the screen, the very first complaint there is ankle sprain. So ankle sprains are off 15% year over year. And then if you go all the way down to the bottom, because it's alphabetically ordered, you'll see pharyngitis, 47%. Those are the pediatric patients. Well, these represent our discretionary patients. And we are going to have to come up with modern, advanced, and novel ways to provide care to them if we still want them to be ED patients. The obvious solution will be they discovered telemedicine. The primary care physicians have opened their offices a little bit more, really not tremendously more. And the insurance carriers have disincentivized them to come to the ED. So if we want these patients, and we are missing them very significantly, 47% decrease in a pharyngitis chief complaint, the solution to that will be reaching back out to the community with technology, with telemedicine. Now, in the middle, the two complaints, chest pain circled in blue and myocardial infarction, very, very concerning, down 19% and 17%. These are concerning patients that should be in our EDs no matter what. They shouldn't be having telemedicine visits. They shouldn't be seeing their primary care physician. They should be coming to an emergency department with chest pain, with an MI. And what's involved there is some community education. The groups that I've spoken with that have reached out to their communities with radio spots, cable TV, newspapers, even billboard campaigns to describe that the ED is here, we are open for emergencies, and you should not stay home with chest pain, MI, weakness, dizziness, shortness of breath. You should come to the ED, and it's a safe environment. And those campaigns have generally been successful and created an uptick in volume of 5 to 10%. Now, we do have a bright spot. We've got a new treatment that's rolled out in the last 2 weeks in most EDs, monoclonal antibody treatment, bamlanivimab. So I think, Lori Jones, we might ask you to mute your line. These patients are COVID positive. They're high risk, but they only have mild to moderate disease. And the drug runs in over an hour, and then there's a minimum 1 hour of monitoring. And we're talking about the clinical component because we have a large physician audience, but also that will drive the way we report these services. CMS mandates that it's an outpatient setting, so that could be an ED, an infusion center, a physician office. And then if we look at the CMS monoclonal antibody infusion instructions, healthcare providers need to have immediate access to treat a severe infusion reaction, such as anaphylaxis. So we're talking about a highly trained provider with a lot of equipment. It's starting to sound much like an emergency department. The hospitals generally get the drugs for free, so they don't charge for the drug itself, but they charge to infuse the drug and monitor the patient. For the facility folks on the line, and there are a couple in the audience that I noticed from years past, M0239, that's your facility charge, includes the infusion and the post-administration monitoring, $309.60 on the CMS fee schedule. Now, what about professional services for bamlanivimab? These patients will come to us in two ways. One, I'm seeing the patient as an ED patient identified through the course of a typical cough, cold, fever, congestion. I don't feel good. I might have COVID. 9928X encounter. I find them to be COVID positive. They are high risk based on some component of their history, and they're symptomatic, but not too sick. They don't need hospitalization. They don't need supplemental oxygen. Well, in the course of this ED workup, I'm now going to order and provide them a medication that requires monitoring. That's coder speak on purpose. So a potentially high-risk medication that's being given under an emergency use authorization with a stated potential for anaphylaxis. So this clearly now feels like a very high complexity visit, probably a level 4, level 5 visit. There's a second way that these patients will come to us. This is very common in some communities. They're sent from the outside with a positive COVID test. Hey, this patient qualifies for bamlanivimab. Please give it to them. These are, again, high-risk patients. They're COVID positive. They have symptoms, but not too sick, but you don't know them. You're not the one who arrived at the diagnosis of COVID positivity and appropriateness for the bamlanivimab. So you need to assess that patient. Why are they high risk? When was the COVID positive test done? How long have they had symptoms? Now, individual hospital workflows will vary, but once that patient becomes an ED patient, EMTALA layers on top of all the medical necessity for the steps that I just described. So a professional charge seems appropriate. And if it's my family member in your emergency department, please see them, perform a history physical exam so that if something goes wrong, you know how to intervene. You're not first flipping through charts or PMD notes to try and figure out the patient's medical history. The infusion is too short. Goes in over an hour, 1 hour of post-infusion monitoring to qualify for OBS, likely not critical care, because if the patient was very sick, they wouldn't qualify for the drug. Now, an exception to that would be if they did have a complication of the infusion. We've had some cases of altered mental status, not much in the way of anaphylaxis, actually. Then fine, that could rise to critical care. Likely, again, a 9928X code, probably a high complexity visit. I'm going to turn the presentation over to Mr. McKenzie, who's going to take us through a very exciting time and changes in the documentation guidelines and the fee schedule. We'll have a momentary AV transition. Mr. McKenzie.
See the bird?
I see the bird, sir.
All right, thanks, Michael. Documentation for 2021. I'm not seeing advance. That's the 1995 documentation guidelines, sometimes called the HCFA guidelines, sometimes called the Medicare guidelines, but they've been around for 25 years. And just to kind of think how old that is, 25 years ago, Forrest Gump was Best Picture of the Year. Michael Jordan was leading the Bulls to championships. And a little show called ER premiered, kind of giving the general public a peek about what really happens behind the scenes in the emergency department, where everybody's beautiful and having some kind of relationship with some other coworker. Not maybe the reality of today. The screen obscured? Everybody can see the whole slide?
Yeah, it looks fine.
Okay, great. For 2021, the changes to documentation are unified, meaning that CPT and CMS agree. If you read the language here, the office or other outpatient visits, the codes that have traditionally been described by codes 99201 through 99215, there's new prefatory language and interpretive guidance that's issued in the 2021 CPT book, and CMS in the final rule says, yes, we are also adopting the MDM guidelines revised by CPT starting in January 2021. This is important because some years, some codes, there's a disconnect between CPT and CMS. That is not a problem in 2021 going forward. So all these codes so far, we're talking about the office or other outpatient visits. Those codes described by 99201, new patients, to 99215, established patients. There are more unique issues to consider in the emergency department or the other E&M code sets. ED is under consideration. The CPT RUC Joint Work Group are looking at ways to take non-office or other outpatient visits and make a similar transition from the traditional elements of documentation guidelines to something that looks closer to what the office and other outpatient codes will see in 2021. CMS in the final rule says we may address sections of the evaluation and management code set beyond the office and other outpatient codes in future years. And that will not happen before 2023. But ACEP's RUC and CPT teams are working on that right now, probably to be considered at the February CPT editorial panel. The traditional 3 elements: history, physical exam, medical decision-making. For office codes in 2021, those are restricted. History and physical drop out of the determination of code level. Now, it doesn't mean you don't have to record a history and physical. It should be as medically appropriate for the presenting patient. It is a documentation exemption, not a performance exemption. So you don't have to do that anymore. That's not what they're saying. It's just that is not the documentation that's going to drive the code level. For the office codes, that means medical decision-making or time. Now, the office codes have a time element, and the prefatory language in CPT says if more than 50% is based on coordination of care or counseling, time can be the driver for that code. But, of course, we know that time is not a factor in the emergency department. It's not a descriptive component. Language like this in the CPT book has been around. In fact, in this last year's 2020 book, there was a special coding tip that draws attention to this in the ED section. Because we don't have time as an element in the ED, that leaves only medical decision-making if we go forward with something that looks like the 2020 office and other outpatient codes. Medical decision-making, the primary driver then for any non-time-based code. There are 3 categories of medical decision-making, 3 elements. Historically, they are listed here, but some slight tweaks in 2020. The number and complexity of problems addressed, formerly the number of diagnoses and management options considered, mostly the same, it's just a little bit different title. The second element, the amount and complexity of data to be reviewed and analyzed, it's now very quantitative, that it's almost a Marshfield Clinic type point system to drive that data. And the third category, risk, complications, and or morbidity or mortality of patient management. It incorporates what we would call the risk table into a MDM grid that is very much like the Marshfield Clinic, if you're familiar with that, to describe level of service. Excuse me. Moving on to the physician fee schedule, we have good news and bad news. First, a little bit of a review. Anybody who's new to the resource-based relative value scale, RBRVS equation, there are 3 elements. Seems like it's always, the answer is 3, always 3 elements. The first is work. This is the physician or non-qualified non-physician practitioner who's providing the service. Emergency physician, PA, NP. The second is practice expense. Practice expense includes non-physician clinical labor, so the nurses, techs, all the other hospital employees who are involved in the care, also supplies and equipment used. Typically, most of that is borne by the hospital. And the third category is the professional liability insurance, malpractice insurance, whereas these first 2 are recommended by the RUC, the Relative Value Update Committee. The third is actually based on actuarial claims made history of malpractice claims by CPT code. So you take those 3 elements, work, practice, expense, professional liability, each has their own RVUs assigned, gives you the total RVUs for any given code. That total RVU times the conversion factor is the Medicare payment for any given year. So let's start with the good news. The good news is in 2021, there is significant increases in ED level 3, 4, and 5 on top of the 5% increases that the emergency department codes got in 2020. So 12.68% for level 3, call it 5 1/3 for level 4, 5 1/4 for level 5. That's good news. In the comparison between 2020 and 2021, you can see that levels 1 and 2 stayed the same. Level 3, 4, and 5 increased, as I just mentioned. But look over here in the practice expense RVUs, slight increases at the higher levels, and the PLI similarly, slight increases in the professional liability, which gives greater total RVUs, especially for the very highest codes. A typical group will see an increase of roughly 0.2 RVUs per patient. So you could do the math on that to see what your likely impact would be. Now the bad news, when you have significant increases in the office or other outpatient codes, which are 20% of all Medicare Part B, they're used so often by so many specialties that that's a significant increase. Of course, non-emergency physicians would probably say, yeah, and those ED guys too, they're getting increases that are cutting our pay. So as a taxpayer, I appreciate that the government is budget neutral. If we spend too much money in one month, we got to cut back a little bit in another month. The table that we always look at, the calculation of the physician fee schedule conversion factor, here shows that all of the cuts, 10.2%, are due to RVU budget neutrality. Putting that in perspective, 2018, the conversion factor basically 36 bucks. 2019 went up about 4 cents. 2020 went up about a nickel. Now we're looking at cuts of about 3.68%, or $3.68, something like that. It's a significant cut going into 2021. This chart is kind of shows you the winners and the losers. Green are increases, red are decreases. Emergency medicine is here in yellow. Basically, any specialty that gets the primary source of their revenue is office or other outpatient codes, they get increases. Biggest winners here, family practice, 13%, hematology oncology, 14%. The losers are those who do not report those codes, and those are historically the hospital-based specialties: anesthesiology, pathology, radiology, and emergency medicine. They don't almost never bill the office or other outpatient codes, so they take a bigger hit than others. Emergency medicine here in yellow, it shows a negative 6%, with 5% at the work RVU, 1% at practice expense, and no appreciable change. Rounding is huge in this kind of situation. But CMS projects minus 6%. That is offset by the increase of the RVUs, but that's where we find ourselves now. The focus, Mr. Gaines will tell you, there's a lot of fires in DC we're trying to put out. But one of the things that we're really looking at, and have been since the proposed rule last year showed cuts of this nature, is some kind of relief from the budget neutrality cuts that are statutory driven. We had hoped and lobbied CMS and the ACEP comments to let them use their waiver authority under the public health emergency, and they felt like that was beyond the scope of their actual waiver authority. We've been lobbying Congress. There is a bill, the Hold Providers Harmless from Medicare Cuts During COVID-19, sponsored by Representative Amy Barra, who is a physician, an internal medicine physician, and Dr. Larry Bouchon, who's a cardiothoracic surgeon, I believe. That bill has gotten some traction. During the COVID-19 pandemic, the optics are not good for a 10.2% decrease in Medicare payments on top of what the losses Dr. Gronowski pointed out in his earlier slides. Significant decreases in volume. A lot of emergency departments have struggled, other practices as well. There's some possibly small context about coronavirus relief. That package, I think, is not going to include that. And there is historic precedent of a 4-year phase-in. Those of you who've been around for all 29 years, Straight Talk will remember that we had a 4-year phase-in when practice expense RVUs changed significantly. So no practice had a crushing burden in the first year. They could kind of phase it in and find some other ways to do that. So formal budget neutrality waiver during the public health emergency or longer, maybe that's going to happen. Advocacy efforts are underway. Here's a link if you want to let your congressional representatives know your voice. I think with that, I will stop sharing and transition back to Dr. Gronowski.
Fantastic. Mr. McKenzie, thanks for laying out all of those issues for us. There obviously are, some significant challenges that are being faced. We're lucky that Mr. McKenzie's CPT and RUC teams had, garnered some 5.5% wins for us. And so that will really soften the blow. I assume everyone can see the next slide, titled 2021 Physician Rule, Telemedicine. So we're going to spend the last couple of minutes looking at some highlights relevant to the ED that came out of the recently released rule. And Straight Talk is typically the first reimbursement conference every year. And this is really, really hot off the presses because the rule came out very late this year due to COVID. The proposed rule was delayed until late summer. And then the final rule, instead of coming out November 1st, came out December 2nd. So this is brand new information. We have good news related to telemedicine. So CMS has created a brand new category of codes for telemedicine called Category 3. And these codes will remain on the list of approved services through the end of the calendar year in which the public health emergency ends. We all hope it'll end in 2021, but let's say the secretary, which could be Azar, could be somebody else, ends the public health emergency in June, then the ED codes would remain on the list of approved telehealth services through the last day of December. And that would give us 2 cycles of rulemaking to advocate for that becoming a more permanent solution. Additional codes, critical care, also on that list as Category 3, and subsequent observation. So initial observation and discharge, they felt like you needed a face-to-face, but subsequent observation, then those are on the list until the end of the year in which the public health emergency ends. And then CMS took the opportunity to reiterate in a fact sheet that was released with the rule that if the provider and the patient are in the same place, that's simply a regular visit. Quote, we are therefore reiterating in this final rule that telehealth rules do not apply when the beneficiary and the practitioner are in the same location, even if audio-video technology assists in furnishing a service. So if the ED doc is on campus and the patient is on campus somewhere, then that's just a regular 9928X visit. Now, what about teaching physician oversight via telehealth? So teaching physicians during the COVID public health emergency may meet the supervisory requirements using telehealth. Does not need to be in person. Quote, the requirement for the presence of a teaching physician can be met through interactive telecommunications technology during the key portion of the service. And CMS put that out early in the pandemic, March 30th, in an IFR. Now, in the final rule, they've made some aspects of that permanent, and some aspects of that will sunset with the public health emergency. If you are in a rural setting, this is a sea change. If you are in a rural setting, teaching physician oversight via telemedicine will be permanent. Teaching physician oversight of residents via telemedicine, if you are in a rural setting, will be permanent. Quote, we're finalizing a permanent policy. This almost never happens, to permit teaching physicians to meet the requirements to bill for their services involving residents through virtual presence, but only if the residency training site, so it's the actual residency training site, and there will have to be some sub-regulatory guidance because the residency training site, the mothership, is often in an urban area that would not qualify, but then all the satellite locations would qualify. The training site needs to be located outside of OMB, Office of Management and Budget, defined what's called an MSA, Metropolitan Statistical Area. And whereas CMS has a number of cool address lookup tools, they do not have a great one for this MSA process. There is a way to research it, and I've looked into it for a number of groups, but it's a little bit of a clunky couple of step process rather than simply type in the address and boom, you're approved. So we're going to need a little more guidance, but a big win for rural teaching physicians. Non-rural settings, we are not permanently finalizing our teaching physician virtual presence policies. However, they will remain in place for the duration of the public health emergency. So for the duration, not until the year ends, the day the public health emergency ends, if you're a teaching physician in a non-rural setting, no more telemedicine oversight of residents. This is an issue that because of COVID has been on the back burner. I'm sort of surprised that folks haven't been talking about it more. So I wanted to bring it up for discussion. There are very significant hospital transparency rules that are taking place in literally 2 weeks. January 1st, 2021, hospitals are required to provide, quote, clear, accessible pricing information in 2 ways. One way is a comprehensive machine-readable file that has all items and services, and it's got a lot of detail. Gross charges, discounted cash prices, payer-specific negotiated charges, and when CMS says charges, they mean rates, so your payer-specific negotiated rates, and then de-identified minimum and maximum negotiated charges. And many hospitals have already done this and started to comply. Now, a machine-readable file is not public-facing. It's not meant to be easy to digest, but there will certainly be third parties, New York Times, Wall Street Journal, Vox, that will scrape that data and put it out there in a tool for consumers to look up. That would have all charges. So that's something to keep in mind. We're going to talk next about who this will apply to. second process, a display of shoppable services in a consumer-friendly format. So this is, you go to the hospital website, and I've seen many of these already. It's very easy to navigate. It's like the CMS star ratings. It's really meant literally to be user-friendly for a 70-year-old who has, less familiarity with technology than, let's say, an 18-year-old. At least 300 shoppable services, and CMS has mandated 70 of them. I've got them in the appendix. The office codes are on there. The ED codes are not. But then the other 230 services, the hospital chooses as they would like. So they could rope in the ED charges. Now, what about the professional services? Where do they fall into this? Well, there are some nice FAQs. Do these requirements apply to non-employed physicians? No. Services provided by physicians and non-physician practitioners who are not employed by the hospital are practicing independently. So if you're a fee-for-service independent group, you're not swept up in this. However, do these requirements apply to the service of employed practitioners? Yes. The hospital price transparency final rule does not limit the requirements to only hospital standard charges. Therefore, if you're an employed physician, your charges will be swept up into that machine readable file. And then secondarily, you probably want to meet with the C-suite and understand if the ED charges will be picked for those 230 discretionary charges that will be very public facing. The machine readable format, I'm not sure how much use that's going to get, but the public facing, user-friendly, shoppable services, the ED codes are not in the 70 mandated. And if there's a desire from the part of the C-suite that the ED services be in that second tranche, the 230 additional codes, then you just want to have some good messaging and good agreement with the C-suite about how you're going to position that process. We're going to wrap up with some good news. Our most vulnerable patients have been well served by the emergency department, but there has been no way to develop a reimbursement paradigm for medication-assisted treatment. I think Dr. Adler has a full lecture on this, so I won't go into all the details. Just from a final rule review perspective, if a patient presents to the ED, they have opioid use disorder, and we want to initiate medication-assisted treatment, we now have a code, G2213, initiation of medication for the treatment of opioid use disorder in the emergency department setting, and includes a bunch of stuff, assessment, referral to ongoing care, arranging access to supportive services, and you report it in addition to the primary service, which would be a high-level ED visit or critical care. Here's a reference out of the final rule. Final rule, 2021, page 542, gets billed in addition to the 9928X codes, 1.30 work RVUs, and 1.89 total RVUs. Conclusions, ED volume is stable. We're still down 15, 16%, and we will have to employ some specific strategies through either telemedicine outreach to our communities or educating our communities for those very concerning patients with chest pain, TIA, stroke, syncope. ED RVUs, as Mr. McKenzie said, are increasing. We need some congressional action now to fix the conversion factor. Telemedicine definitely growing, particularly in rural areas. The regulatory environment has never been more complex, so stay tuned. My contact information is here as well as Mr. McKenzie's. We interact with folks throughout the country on a regular basis, typically by email, though phone numbers are provided. We just ask that you provide a little bit of context. Hey, Mike. Hey, Dave. I heard your lecture at Straight Talk and have a follow-up question. Thank you very much. And we'll see if we have what we've got in the chat here, David.
All right.
Looks like the question you had was answered.
All right.
Yeah, so the question was, do we see these trends in ED volumes being something that's persistent in the future, or do we think this is temporary and just COVID related? And your answer, Mike, was that, we do think that there's probably going to be, with some of these low acuity visits, we may not be able to retain those, but native population will continue to increase once COVID gets under better control. So thank you guys very much. Appreciate the talk. You guys did an excellent job. So for our next lecture that we're going to be getting into, we have a update on surprise billing on the federal level, and that's going to be provided by Ed Gaines.
Thanks, Dr. Gradson, Mike and David. Thank you. Hey, everybody. Can you see my full screen? Are we good? Hello?
We still have Mike's screen up.
Oh,
There we go.
There it is. We're good.
All right, we're good. Great. All right. Well, a lot happening. I'm Vice President Regulatory Affairs for Zotec Partners. Here's my faculty disclosure. And let's get right into it because Dr. Lamther is going to talk about the Michigan updates. So when we were talking about doing sections of this program, I volunteered for this back like 6 months ago. And little did I know that Friday night, this last Friday night, Congress would drop nearly a 400-page new bill on us, the No Surprises Act, from several different committees. And so you can imagine my initial reaction was, God help me, what was I thinking? But also my continued fear for the doctors in the audience, and you can help counsel me on this, that my grave marker will say he worked on surprise medical billing. So it's one of those issues that kind of found me, or I found it, but whatever we have, emergency medicine has been a leader in this field for many years and is looked to today as a reaction. So I'm going to take you through very quickly what's happened at the federal level in about 5 minutes. And then Dr. Lamther is going to talk specifically about Michigan. So this chart from Kaiser just shows you the dynamics of today's healthcare marketplace economics. And that is that deductibles have greatly outstripped workers' earnings or their premiums or overall inflation. So the patients are one of the largest payers in healthcare outside of the governmental payers. So if you're a physician group or a hospital-based doc, you're saying to yourself, well, you know, typically in our client base, anywhere between 3 to 5, maybe 7% of their payers are out of network. Groups want to be in network because it's easier to be in network. They send you the money, the remit, the patient's limited in their cost sharing, et cetera. Well, here's what the Nonpartisan Congressional Budget Office, which scores all the legislation, they have to score it for either savings or costing money. And in this case, the Energy and Commerce Bill, which formed in part as a basis for this new law, said that CBO said that there would be 20 billion, quote, in savings, which means increases in corporate taxes due to the reduction in medical expenditures over 10 years, because rates would converge around what's called the median in network rates. And what CBO said was very stunning because, again, they're nonpartisan, they're objective evaluators of these pieces of legislation. They said 80% of those savings would come from the decline in in-network rates. Because what would happen is any rates above the median in network would matriculate down to that median. And that's how they scored that legislation. CBO has come out essentially with the new law and said the same thing, very similar things. So just to take us back very quickly in time in terms of where we were, we were in late fourth quarter of 19, in football analogy terms, we were out of timeouts, running the 2-minute offense, down 4 points, and then Chairman Neal from the Ways and Means Committee came in and said, hey, wait a minute, we're going to put the stop on this because we don't like several aspects of it. So what's changed now is his committee and his ranking minority member are now behind this new compromise that was just announced in a bill Friday night. Okay, so what are we looking at? And what I've done here is I've taken the actual committee summary of the document, again, 400 pages. There's a link here to the political article, but let's start out. First of all, it would hold patients harmless for surprise bills. And what's the health plan impact here? You're talking about ACA, ERISA plans, federal employees health benefit plans, and any plan, including grandfathered plans, if you're in a state that does not currently have a formula. Now, Michigan now does. So I think the way this settles out is under the terms of the bill, assuming they're passed and not changed, is any state like Michigan that has a formula, that formula will apply, except for ERISA plans. Remember, ERISA plans are governed at the federal level, and generally speaking, the federal law controls those plans. So in some states, ERISA plans can represent a huge portion of the overall plans. In the state of New Jersey, for example, is estimated more than 70%. In the state of Georgia, over 60. So what's going to happen? The patient's going to be limited to their in-network cost sharing, just like the Michigan law under federal law. But several things happened, changed this bill from April of 19 or fall of 19 to now, and we want to touch on that. So independent dispute resolution will be permitted. There is batching allowed. There is no monetary threshold. Those were important changes that ASAP, EDPMA, and many organizations advocated for. And folks, let's be clear, this bill is much better than the bill that we were looking at that Senator Alexander, who's pictured below, wanted to impose upon us, and his colleague in the House, Representative Frank Pallone of the Energy and Commerce Committee. So many changes were made that are beneficial to us, and that's a good thing. That was a result of advocacy and the fact that we wouldn't go along with this bill last year. Now, here are the factors. If you look here in the fourth bullet, what does the IDR entity have to consider? They have to consider providers' training and experience, patient acuity, but they have to consider the median in-network rate. They cannot, by statute, consider charges. Charges are barred from the discussion. You cannot bring in charge information at all. What else is allowed? Interestingly enough, the market power of both the physician group, if there is market power, or the plan in that geographic area. The teaching status, that's new. The case mix, scope of services, and the demonstration of good faith efforts or lack thereof to try to come into network. So those are pretty good factors. Here's where we have problems. Number one, there's no prohibition on Medicare and Medicaid and governmental payer payment standards coming in. That's a problem. And there's no independent, transparent database. There's no fair health. There's no visibility. So the plan can come in and say, Dr. Gratzen, this is our median to network rate, and you have no visibility into whether that's true or not. You can challenge it, but you can't bring in charge information. But here's where we really have problems. And that's the last bullet here in the shaded portion, the fifth bullet. Providers can only bring one IDR. When they bring that IDR, they have to wait 90 days. Let me give you a very quick example. I see Dr. Powell in October. The health plan notifies him that they're going to pay 125% of Medicare. Then there's a 30-day period, let's say November 1 to November 30, where there's a discussion if he doesn't like that rate. Okay, so then there's a waiting period. After that 30-day waiting period, he has 2 calendar days. So we'd literally have December 1st or December 2nd to file an IDR. Let's just say the IDR, there are a number of timeframes in the statute, but let's just say the IDR takes 45 to 60 days to get fully adjudicated. So we're now at the end of January, okay? All of December, all of January. We're at February 1, he finally gets his payment. He now cannot file another IDR for February, March, and April. Here's where the statute's got a problem. It doesn't say that he can bring his December and January claims. There's no allowance for the claims that were occurring during the time that he was having the IDR. There's specific authority that says claims that are occurring during the 90-day period can be brought. So that's a huge issue. So first of all, Dr. Powell could only bring maybe 2, possibly 3 IDRs in 1 year. And there are going to be several times, because those IDRs will take a couple of months, where they could be 4, 6 months worth of claims that don't have any visibility into IDR. So these are definitely problems. I want to finish up here quickly. There is an exclusion for patients who are notified 72 hours before a scheduled case, a non-emergent case. and they can be responsible then for surprise medical billing. Air ambulances are covered. There is some transparency requirements for the health plans, which is a positive thing. There are a number of reports that both GAO and the secretary have to issue. One that's after 4 years. We don't like that. We think it should be sooner. There's also the establishment and funding of a state all-payer claims database. So I mentioned Fair Health. We've talked about Fair Health over the years, but a state all-payer claims database is authorized. Here's a problem for anybody in the revenue cycle business, and this is a big problem. First of all, the patient has to receive some kind of a list of services. It's not really clear, and it would be presumably defined in regulation of what they had within 15 calendar days of the date of service. So presumably that's some kind of statement or electronic notice that describes, I suppose we have to describe what a 99285 is to the patient. We don't know. We honestly don't know. But here is a big problem. The third bullet. If a patient receives a bill more than 90 calendar days after the date of service, the patient is obligated to pay. Think of your auto payer class. Think of your workers' comp payer class. There are oftentimes, frequent times, when auto and workers' comp are not adjudicated, and you in workers' comp situation, you simply cannot bill the patient unless workers' comp is determined not to have been applicable to that patient's injury. So in those cases, you might be barred from billing. So that has a particular impact on emergency medicine, and we're commenting vigorously as we speak on that now. So just very quickly, what we have seen in Texas, this is based on the 6-month report. Here is, if we can get a meaningful, accessible IDR process, it can really make a difference. Now, Texas allows Fair Health charges, 80th percentile, and Fair Health 50th percentile of allowed amounts to come into the IDR decision. But look at this, 32,000 IDRs filed in the first 10 months of the Texas law, 86% by EM docs. When there's a settlement, EM is getting, doctors writ large, not just EM, are getting 4.43x of the initial payment. When there's an adjudicated IDR, they're actually getting close to 4.75 of the initial payment. So that's the kind of IDR we're looking for. Georgia's going online in a couple of weeks. Georgia's going to be even better than Texas, I predict. So there we are. Very difficult to predict if this is going to pass. We will literally know in the next week to 10 days. And we're happy to take questions. And I want to transition over to my good friend Warren. Here's my contact information. As Mike said, if you have questions for me afterwards, please kind of reference where you were, where you heard from, and I'll be happy to answer your question. All right, Dr. Lamphere.
So I'm actually going to make things a 30-day review comment period.
Warren, I think you're still muted.
Sorry about that. Good morning. I'm Warren Lamphere. I'm an emergency physician from West Michigan. I work for emergency care specialists. I'm also an officer with the Michigan College of Emergency Physicians. I'm going to talk to you this morning about the Michigan surprise billing law that was passed this year. So it's known officially as the Enrolled House Bill 4459. So that's a number we all think about of it as 4459. It's Act number 234, Public Acts of 2020, if you're trying to find it. It was actually signed into law by Governor Whitmer on October 22nd, 2020, and it's effective immediately. So we knew that there were some attempts to initially thought that we could maybe get, if it got to her, that we could talk to her about vetoing it, but really it's, nobody wants to be against the surprise medical billing, even though there's things that aren't, very unpopular and unfair as we would see it. if it got that far to her desk, that it was going to be signed. So it was signed, it's effective immediately. However, the requests for review of payments, if they're calculated wrong, or a request for binding arbitration can't be made until July 1st of 2021. So there's a few wins for providers, but very few. The original bill was required non-participating providers to accept payment of 125% of Medicare. We were able to get that through advocacy changed to 150% of Medicare, or the median in-network rate, whichever is greater. And I think Mr. Gaines talked about, how that median network rate, and Mr. Gronowski, or Dr. Gronowski as well, how that can just, it slowly drives it down. But we were able to get that up pretty early in the negotiations. The out-of-network providers receive payments directly from the insurance company. So this was important. It was a small win, but initially that wasn't in there. And, I was at some hearings where, we made a point of stressing that, and Blue Cross, who was well represented at every possible meeting, as you can imagine, would, say that was their, way of enticing us to participate. So thought it was important, but we were able to get that out of there. So the problem with the bill really is difficult to appeal. Non-par providers may request a DIFs, and DIFs is Department of Insurance and Financial Services. That's who kind of oversees this process, and we can request, again, not for another 6 months. If the payment was calculated incorrectly, we can also file a claim for additional payment based on complicating factors, and these are the modifiers, and you basically would have to show that, that there was additional time and effort and complicated medical decision making, and then if you're requesting it, and so that payment would only be 25% more than the initial payment if you get that decision goes in your favor. The carriers at that point can pay that, or they can offer an alternative, or they can deny that. So at this point, you can request binding arbitration. The DIFs keeps a list of accredited arbitrators. They're independent. They have this list, and they can propose and hope. And the idea is the carrier and the provider would agree on the arbitrator and move forward at that point. However, this is one of the what problems that we were. One of the losses we had, the non-par providers and carriers each pay half of the total cost of arbitration. So we were advocating for, the loser pays the entire part, but it's every time you go to that you share in the cost of that equally. The concept of threshold, it wasn't, and batching are not addressed, whether they come out in the regulations that DIF set up in order to administrate this. I don't know, but it's not in the actual legislation itself. They don't address having to have a minimum threshold or being able to batch your claims. You can't, they did state in the legislation that you can't come back to them later asking for another decision based on the same type of claim and deny, that you can't do. So once they made a decision on that, you can't come back with somebody like that in the future from the same carrier. Kind of review of the effect of the, DIFs is required to file an annual report regarding patient billing complaints, carrier network adequacy, requests for payment review, and requests for binding arbitration. So they have to gather this data and then present it to House and Senate committees each year. MSEP, the Michigan College of Emergency Physicians, requested that Governor Whitmer direct DIFs to monitor the new law for any adverse effects on physicians in Michigan. And this request was granted. How this will actually take place, and we'll have to watch for that. But there was an agreement that we're going to watch this, if this is going to have an adverse effect on our practice, as we were predicting. There'll be noticed and then some action taken. We'll see if that happens. And MSEP has also been assured that we will meet with DIFs and be included in their monitoring process in 2021. So kind of outlook, the legislation, it legislates the reimbursement rate, which will have an effect on contract negotiations. So now that, that 150% of Medicare is in there, is in the statute, and it becomes, that downward pressure to start, over time accepting that as the norm, and it's very difficult to negotiate anything above that. Contracts can be canceled by carriers, making providers out of network and subject to these provisions. So that's what we're really worried about, that, a carrier can do something, they can claim that the contract they have with you no longer brings value to their customers, and cancel it and force you to renegotiate, and then you're immediately out of network, and then we're subject to the provisions in this legislation. Second point, the arbitration is difficult to access and costly. You have to pay for half of it every time. Easier done by carriers than physician groups, but it's a difficult process, so it's not going to happen a lot. When I saw some of the data that Mr. Gaines was presenting from Texas, like there's been thousands of these requests for arbitration. It'd be interesting to see if that how that will play out in Michigan. If the claims can't be bundled, there's no provision again for bundling or batching them. Again, that may come out in the actual regulations, but it's not mentioned in there. So that the cost increases if they can't. If you have to pay for the arbitration time, it takes place. That's kind of like where we see it. So some of my personal thoughts on the whole process of, advocating, our college advocating for this, and also, we did a lot working with the Michigan State Medical Society. It's obvious that Blue Cross is a powerful lobby, and they have the ear and the pockets of the legislators, and they worked with them carefully to kind of counter arguments to everything that we had proposed. And then really one of the main was, it became evident that the lawmakers felt that it really wouldn't affect emergency physicians very much. They know that we, as mentioned previously, that we almost always participate with the carriers, the hospitals that we serve. We kind of almost always require that. So it's rare that we wouldn't be participating. It's usually when you have somebody from out of your region that gets care in your ear, and they may have an insurance that we don't participate with. But for the most part, we do. So they saw it as a rare time when we're going to have one of these cases. What were we making such a big fuss about? They really didn't think it was important to make some of these changes that we asked for. They really didn't believe the access argument, where we felt like this can really affect patients' access to care and the care of specialty consultants, especially in rural areas, and it could affect provision of emergency medicine in rural areas. And then they just didn't buy that. They didn't understand it and really didn't buy it. The final thing was, we were in the midst of the pandemic, and we had numerous phone calls dealing with COVID with new legislators, both of the Medical Society and MSEP. And whenever we even brought up that issue of surprise medical billing, it's like, well, we know you guys are busy, and you're under a lot of pressure working, fighting the pandemic, and this isn't, we shouldn't talk about that. And then the first session that was of the state legislators came back to in June was to discuss this. So there was kind of lip service paid to that. You're the heroes. Let's put this off till we're past the pandemic. And they were intent on getting it practiced this year or passed this year. And despite, I think we were always at the table, but it was frustrating to not really be treated as the heroes that we kind of thought we were, and we could have this issue dealt with at a time when we didn't have other issues, like trying to make sure we had enough PPE and that type of thing, making sure telehealth was was work right. So that's my look on it. It was unfortunate, but the legislature was determined to get it passed this year, which they did. That's all I have to say. And then thank you for giving me the opportunity to speak to you this morning. I think at this point we're going back to the virtual vendors, so I'll turn it back to the directors of the meeting.
Thank you, Warren. I just wanted to take a moment to acknowledge a question by Don Powell to Ed Gaines that asked if he could touch on the thought that states may refer back to federal legislation, even if active state legislation reportedly per governor's discretion. So, Ed, I saw that you posted a comment in the chat. I wonder if you could care to explain.
Yeah, so the bill is written, defers to a state solution, as I said, if the state has a methodology for payment and disputes. And so that would cover your group health plans, your state, the ones that are applicable today. And then the ERISA plans would generally be covered under the federal law. Now, I mentioned that some states have actually provided in their state law the ability for ERISA plans to opt in. Don was suggesting that there perhaps he's hearing that the governor might have discretion to refer to federal legislation, which I'm not aware of if it's the case. In Michigan, as Dr. Lamfair was just saying, it might benefit you actually if this federal bill passes, if you were able to be applicable to the federal bill as opposed to the state bill, because as I mentioned, there are problems with the federal bill, but things like batching, baseball style arbitration with the loser pays, all of that are in the federal bill now. They weren't a year and a half ago, but they are today. So in some ways, the federal law would be more beneficial to you.
All right, thank you, Ed. All right, so our next up on our agenda is we have some time here, 30 minutes, to go into some breakout rooms to spend some time with our sponsors. So I encourage everybody to try to get to as many sponsors as you can. We're also going to have this opportunity to do so tomorrow. Also, just note that to get back into the main Zoom to be able to continue on the conference at 10 o'clock, you can use the original link that you used to access the conference here today. So that is an option. So if you look in your chat, you can see that we have the links for all of the breakout rooms. So we'll take the next 30 minutes and have a chance to visit with our sponsors. All right, so thank you very much.
I kind of drill down a little bit deeper into what Mr. McKenzie had talked about with the 2021 updates for CPT, specifically about the medical decision-making process, and maybe talk about a little bit how that could eventually relate to emergency medicine. So CMS has told us that they're going to adopt the CPT's suggested MDM guidelines for the office visit codes effective January 1st of 2021. But they have also stipulated that it only applies to the office visit codes 99281 through 99285. And because they recognize the practice specifics of emergency medicine. And so they're not prepared to translate these specific rules over to the emergency visit codes yet. But there is already a process in place where committees are talking about how do we transition this MDM guidelines over to the entire set of E&M codes. The goal from AMA and CMS perspective is to have one set of guidelines that applies to all practices. And I think there's going to be a little bit of a challenge to that process. But AMA feels that by providing their MDM rules that we get some consistency across all the payers. From that perspective, I certainly applaud this concept in that, as coders and auditors, we have to deal with every payer putting their own spin on the Marshfield Clinic scoring system and every, the various payers looking at the different levels from a different perspective. So for the new codes, or with the new guidelines, it would be driven by medical decision-making or it would be driven by time. And then the clinician will decide how much history and exam would be documented. And that's going to be up to the individual clinician. So for this particular patient on this particular day, what level of history and physical is clinically necessary. And then we'll score the visit based on medical decision-making, or they can use time as the component for picking their level of service. But as we know and have always said that the time is not a factor in the ED codes, They recognize that time is not a factor for the ED codes. Matter of fact, CPT 2021 kind of highlights the concept that time is not a factor for emergency department visits. So with the transition to the new guidelines, there are some of the elements that I think are beneficial. In the new guidelines, they have defined or removed some of the statements that left room for debate, things like mild versus, or chronic versus acute. And they've also given us some definitions on things like the independent historian element. So if you're going to try to get up to speed on the new MDM guidelines, you're going to want to go out and find two documents. The first is a 16-page document from AMA that describes all of the new descriptions for the office visit codes, but also it gives us all those various definitions, and I'll highlight some of those that will probably be beneficial or detrimental to emergency medicine. And then the second document you're going to want is the MDM grid. And so this is specifically straight from the American Medical Association and CPT. And as the federal rule states, CMS is going to adopt this as the methodology for assigning MDM for the office visit codes. I think, and we'll again stipulate this is specifically for the office visit codes, but I think we might be a little naive to think that some of the payers aren't going to try to use some or all of this to when they audit the ED visit codes. United Health has already started to use some of the language from the 2021 MDM rules in their discussion of things like medical decision making for ED visit codes. They've already replaced their discussions about number of diagnoses or treatment options as a part of the MDM with the number and complexity of problems addressed. So I do think it's important that even though we're not going to be coding by these guidelines for 2021, we should familiarize ourselves with them because we may end up having to face them in an audit scenario. So if we tour around these MDM grid a little bit, we can see under low number or complexity of problems, it gives us a couple of options, 2 or more self-limited or minor options, 1 stable chronic illness, or 1 acute uncomplicated injury. We'll recognize these terms from the current risk table. And we usually consider acute uncomplicated illness is where most of our ED visits start and then work their way up from there. We can move up to moderate, 1 or more chronic illness with exacerbation, 2 or more stable chronic illnesses, 1 undiagnosed new problem with an uncertain prognosis, acute illness with systemic symptoms, or 1 acute uncomplicated injury. And then we'll make our way up to high for 1 chronic illness with severe exacerbation, or 1 acute or chronic illness that poses a threat to life or bodily function. One of the things that they do talk about in that 16-page document that I mentioned earlier is the multiplication of symptoms. So we see that, under minimal, it says 1 self-limited or minor problem, but then if you have 2 self-limited or minor problem, it moves us up to low. So even though there are some examples where they don't specifically give us a number example, for example, 1 acute uncomplicated illness or injury, I think that if there's a multiplication factor there, that we have room to maybe debate that it's moving up to the next level if it comes down to that discussion. If we look at data, that's where the biggest difference is that we're going to see for those of us that are used to the Marshfield Clinic scoring. So for limited data, we've got to meet at least 1 element from either category 1 or from category 2. Well, category 2 is pretty easy to meet. There's only 1 option, the assessment requiring an independent historian. We do have a new definition of independent historian. And then for category 1, we have to have at least 2 of any of the following elements. So we need to take review a prior note from somewhere, or order a test, or review a test. That asterisk next to each one of those, where it says each unique test, is defined at the top of the grid and tells us that each unique test applies to these categories. So that is going to be the one benefit and the one significant change we see in comparison to the Marshfield data points is with Marshfield, you order 1 test or you order 10 tests, it's still just 1 point for review and order of lab tests. Whereas here, we get credit for each individual test. So if we've ordered 2 tests, we've met the requirement for category 1 because we have a combination of 2. We get credit for each unique test. We move up to moderate. To qualify as moderate data, we have to meet any one of the categories. So category 1 has moved up from 2 to 3. So we need any combination of 3 from the following elements. And then also assessment requiring an independent historian has moved from being its own category, and it's gotten lumped into category 1. And then we've added in category 2, independent interpretation of a test. So if we do our own X-ray or EKG interpretations, we satisfy the requirement for category 2. And then category 3, discussion of management or test interpretation. So it's the old discussion case with another provider or history from another source. And then to move up to high risk, we need 2 of the 3 categories. So we need to meet the requirement from at least 2 categories. For category 1, we need at least 3 of those following elements. And then we need to add to that either our own interpretation or discussion with another provider. For the risk tables, there's been some minor changes. Low risk, they don't give us any examples. It just simply says low risk of morbidity from additional diagnostic tests or treatments. That's where we're used to seeing, over-the-counter meds, minor surgery, no risk factors, but they don't define those in the new grid. Moderate risk, they give us examples of prescription drug management, decisions regarding minor surgery with risk factors, decisions regarding elective surgery, no risk factors, or diagnosis or treatment limited by social determinants. So that's actually a kind of a win for emergency medicine because we do have those patients where their home condition or their social relationships do impact our treatment process. If we may not be comfortable sending a patient home because they live by themselves, or we may not be comfortable discharging an indigent patient that's not going to be able to follow a treatment regimen, does have an impact on our risk selection. And then for high risk, our examples are drug therapy requiring intensive monitoring, the decision for major surgery with risk factors, the decision for emergency surgery, the decision for hospitalization, or the decision to do not resuscitate or de-escalate care. So let's drill down a little bit deeper and look at some of the definitions that they've given us under number and complexity of problems. That opening document, that 16-page document I mentioned, they do go through and define some of those elements. They talk about what our comorbidities and underlying diseases are. They tell us that it doesn't specifically increase our level of service, but can increase the level of risk. And one of those statements that I think is extremely beneficial to emergency medicine, the final diagnosis of a condition does not in and of itself determine the complexity of a risk. The extensive evaluation may be required to reach the conclusions that signs or symptoms do not represent a highly morbid condition. Well, this speaks directly to the argument that we have with most payers. We have a lot of payers in our field right now that are coming out with emergency diagnoses lists, and that's driven purely based on the ICD-10 code assigned. But what they're telling us here is that a patient that presents with a complex presenting problem that goes through an extensive evaluation to arrive at a final diagnosis, and for those times that that final diagnosis does not seem complex, that the presenting problem should be and is our driving factor on our level of service and the level of medical decision-making. They give us a definition of a problem. Problem is addressed or managed when it's treated or evaluated by the physician. And part of that includes considering further testing or treatment that may not be elected by virtue of either a risk-benefit analysis or the patient or parent decides not to do that. So for those cases where we want to admit the patient to the hospital and they decline to be admitted, that doesn't change the fact that we may have a high risk or high medical decision-making encounter. And where that really comes into play, I think of those patients where, a patient has a blow to the head and we discuss the risk and benefits of getting a CAT scan. I think for most of us, from a coder's perspective, if we have a patient that, hits their head and gets a CAT scan, we kind of default to that being at least a level 4 visit. But on another patient that bumps their head and they don't get a CAT scan, we kind of feel like that may be more consistent with a level 3 type visit. But if there's not a CAT scan ordered, but the physician documents that we discuss the risk and the benefits of getting a CAT scan, don't feel like this would change my treatment for the patient at this time. The parents are comfortable taking the patient home and monitoring them. So I think that documented consideration of further testing and weighing the risks versus the rewards, I think is still beneficial and still would support a higher level of medical decision making. They give us some definitions of the common phrases from the MDM table: acute illness with systemic symptoms, illness that causes systemic symptoms, has a high risk of morbidity without treatment. And this is one of those that I think is detrimental to emergency medicine. Systemic general symptoms such as fever, body aches, or fatigue, and a minor illness that may be treated to alleviate symptoms or shorten the course of treatment, or to prevent complications. See definitions for self-limited or minor. And I kind of have a problem with that because traditionally, if I have a patient that presents with, a fever, I consider that a systemic symptom because it does include or does indicate that the likelihood or possibility of systemic involvement, underlying conditions, underlying infection. And certainly with the environment that we're in now, a patient that presents that's having fever plus body aches plus fatigue, they're going to get probably going to get COVID workups. And so those are going to be high level medical decision-making cases. So I think discounting some of those symptoms and referring to them as self-limited or minor, I think is a disservice to the emergency physician practice, and certainly with the environment that we're in now. For the definition of chronic illness with severe exacerbation, severe exacerbations are side effects of treatment that may risk morbidity or may require hospital level care. Then acute or chronic injury or illness that poses a threat to life or bodily function. They kind of tell us that these are things that pose an immediate threat to life or function without treatment, and they give us some examples: acute myocardial infarction, pulmonary embolus, severe respiratory distress, psychiatric illness with threat to their self or others, acute renal failure. And I agree, those are all life-threatening conditions, but the problem is those are all final diagnoses. And I think we may have a problem at some point in the future if we have a patient that presents with symptoms that could be indicative of those life-threatening diagnoses, but those diagnoses end up not being our final diagnoses. Like I said earlier, there is committee discussions and processes in place where they're starting to evaluate, how to apply these guidelines to all the E&M codes. And one of the things that I've kind of suggested in those types of discussions is that we simply add in the phrase symptoms of in front of those diagnoses, so that we have a leg to stand on when our final diagnosis may not be a myocardial infarction, but they presented with symptoms of a myocardial infarction. And that would make it a little bit easier for us to support those high medical decision-making cases on encounters where the final diagnosis isn't necessarily that significant. And then if we drill a little deeper into the data element, like I said, the asterisk tells us that each unique test, order, or document contributes to a combination of the 2 or combination of 3 required for category 1. And that's a big win for us because we do have those cases where the patient gets multiple labs, multiple x-rays to help support those higher level of data, where within the Marshfield scoring, we don't necessarily show that as an increase in the data complexity. We have a definition for independent historian. Anybody besides the patient that gives us information, parent, guardian, surrogate, spouse, etc., that provides a history if the patient is unable to give a complete or reliable history. An example, due to developmental age, dementia, or psychosis. So that due to developmental age, again, helps us and eliminates that debate we have sometimes with taking a history from a parent on an infant. So they're telling us that taking that history from somebody else because of the patient's developmental age is an element of the data component. More definitions under category 2, the independent the independent interpretation is the independent interpretation of a test where there is a CPT code and an independent interpretation to report a customary. But I have yelled and screamed and jumped up and down about this. The discussion this does not apply when the physician or other qualified healthcare professional is reporting the service or has previously reported the service. So this is going to favor the insurance heavily, and the payer heavily, in that what they're saying is if we bill for the EKG, or we bill for the X-ray interpretation, or we bill for the ultrasound interpretation, we don't get credit for that as a category 2 element for the independent interpretation. We have to battle this a little bit now with some of the payers that have their points versus pay policy. So under Marshfield Clinic, right now, we get 2 points for the independent interpretation. There are some payers that we have to make the decision. Well, do I count these 2 points to show an increase in my level of service, or do I bill my 93010? And so CMS and MA have just finalized that and said it's one or the other. We can't ever do both. And then a little bit of when the form of interpretation should be documented does not have to consist with the standards of a complete report. So I think as long as we know that the provider has done that interpretation, it doesn't necessarily have to be a fully documented interpretation to qualify for the data category. And then in category 3, external physician or other qualified healthcare professional is anybody of a different practice or a different specialty. But then they tell us that the appropriate source can also be a non-clinician, lawyer, parole officer, case manager, teacher. And I think that's beneficial, because I've tried to argue in audits in the past where I've said, well, we had a discussion with another healthcare personnel because we talked to a social worker or we talked to a case manager. And that discussion was very germane to the treatment and evaluation for that patient. And auditors have refused to give us credit for that because the Marshfield system specifically says discussion with another physician. Although that does stipulate, does not include discussion with family or informal caregivers. And then if we drill down a little bit more on the risk, for the purposes of medical decision-making, the risk is based on consequences of the problems addressed at the current encounter, and does include risk associated with either our decision to order tests or the decision to forego further testing. So again, I think we get credit for those discussions in that medical decision-making component where we elect not to do a test or a procedure where we've weighed the pros and cons, or even the decision to admit the patient to the hospital where we've weighed the pros and cons. So if we look at how this may affect our code assignment, if we look at kind of a standard ED visit that we've always used as the median example of 99283, we have a patient with aversion injury to the ankle. Exam shows tenderness and the dorsum and right foot. X-ray is negative. We put on an ACE wrap and wrote a prescription for Toradol and discharged the patient home. So if we look at how this scores, we're going to call that an acute uncomplicated injury for number of problems. We're going to get credit for ordering the X-ray. And then if we do our own independent interpretation, we've met category 2, and we write a prescription for the Toradol. So the requirement to qualify for a given level of service is meet the 2 out of 3 components. So this is going to qualify as moderate medical decision-making because we've satisfied moderate data because we met at least one element under one of the 3 categories, and we've written a prescription. Now, what happens if we did not do our own interpretation of the X-ray? Then that's going to cause us a little bit of a problem because under moderate data, the requirement for category 1 is any combination of 3 from the following. Well, since we didn't do our own interpretation, we can get credit for doing the review of the results of the X-ray, but that still only gets us 2 elements. So unless we're able to add in another test or getting information from an independent historian or reviewing a prior note, we're not going to meet the requirement for category 1. and there's no indication that we discussed the test with or the case with another provider. So we're going to be stuck with limited data for that particular patient, which means now what would normally be a level 3 visit, inversion injury with an ankle x-ray and prescription meds, has been a level 3 visit since the codes were released in 1992, is mathematically going to score as low medical decision making and limit our code choice to 99282 if these guidelines are applied to the ED visits. One more quick example: patient presents with shortness of breath for the last 3 weeks. There's been multiple COVID positive tests at his workplace. He's had short of breath, pain in the lower part of his chest. It's worth when he takes a deep breath. Describes it as a pleuritic pain. He's tachycardic and visibly uncomfortable during the evaluation. We order the D-dimer, the EKG, multiple labs, and give him an inhaler while he's in the ED. We do a rapid COVID test, do a chest x-ray. Our physicians documented the EKG results. Looks like his D-dimer and chest x-ray labs all came back normal or negative. We gave him some counseling about his strict precautions to look out for worsening shortness of breath and his chest pain. Did the breathing treatment, wrote him a prescription for Zofran, and sent him home. So if we look at how this is going to score, I'm going to say presents with chest pain and shortness of breath is an illness that poses a threat to life or bodily function. We've done a whole bucket full of labs. So even though within that category, we're only going to say we've met, ordering each unique test. So we get credit for each individual test. So we've met the requirement for category 1 with just lab tests. And then we've documented our own EKG interpretation, and then we wrote them that prescription for Zofran, or we gave them the breathing treatment in the ED. So again, the requirement is 2 out of 3 under a given level. So it qualifies as high medical decision making. But again, if we bill for that EKG and are not able to use it as our category 2 requirement, that's going to leave us in a little bit of a problem, in that to qualify for extensive data, we have to be able to add in either category 2 or category 3. In this example, we did not discuss the case with any other providers. So even though we've got a whole bucket full of labs, and we've well exceeded the requirement of 3 elements for category 1, we're still not going to be able to get to extensive data. So that's going to move our medical decision making from high down to moderate, and is going to limit our ability to report the 99285 and cause that to be a moderate medical decision making for 99284. So there's probably going to need to be a discussion within the practice, if these guidelines do get applied to emergency medicine, is within your practice, you'll have to decide, either across the board, do we no longer want to bill for our EKG interpretations, or should it be a case-by-case basis where the coder has the authority to make that decision? And then if I were coding this chart, you'd say, okay, ding, 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 these are my points, but I build my EKG, which means I can't bill a level 5. So on this case today, I'm going to make, as the coder, I'm going to decide we're not billing this EKG so that I can report the level 5 visit. And you guys in the practices individually will have to do a kind of a cost benefit analysis to decide, when do we bill the EKG versus when do we let it apply to the data points. I think that's all I have for you on the new E&M, or the new medical decision-making guidelines. Again, we'll stipulate that this does not apply to the ED E&M codes for this year, but we do have plenty of emergency physicians working in urgent care centers and staffing urgent care centers. So it is going to be a factor for them. And I do think that we will probably see some of the payers that are some of our, that we have our most fights with, specifically United Health and some of the Blue Crosses, that are going to certainly try to cause these or use these to bleed over into their decision-making for the ED visits when they do their audits. So I will relinquish the screen back to Dr. Gronowski to go into the MIPS codes. Real quick, there was a question in the chat. Assuming that you're interpreting both the EKG and the X-ray in your documentation, can we use the chest X-ray? Can we use the chest X-ray to meet category 2 and then use the EKG to build the CPT code? And yes, we can. So we can certainly do, as long as we have multiple interpretations, I think we can spread those out across that decision-making process. Sandy, yes, I will make sure that the links to those documents are available. I was actually trying to do that as I was prepping during the break, but they're on my desktop, so I always go there first. But I'll make sure those are available. And then the other question on the current guidelines are CPT coded things and currently points still mutually exclusive. So the question I think is the points versus pay. Navin, if I have your question wrong, I apologize. So under the current guidelines, can we bill 93010 and also get 2 points under Marshfield data scoring? In our practice, we do count them both. I know there are payers that have said they don't allow that, and I've had some success pushing back on those. Specifically, WPS has, in one of their newsletters a couple of years ago, that it's one or the other. You either get the 2 points or you bill the EKG, but you don't do both. Even in audits with WPS, I've been able to get the auditor to understand why those two things are different components. But it's one of those areas where you want to be aware of your local payer policies. Some payers don't allow you to do both. In our practice, we do count the 2 points and we bill the 93010. So Dr. Gnoski, I'll pass it off to you and let you go into MIPS. I appreciate everybody for listening in.
Thanks for that great discussion. Obviously, a lot of transition taking place, and Mr. Thomas is one of the folks who's really spent a lot of time digesting this material. We're going to spend the next 30 minutes going into a MIPS update for 2021, merit-based incentive payment system, a very, very complex process. We're going to start at a very sort of basic level, build some foundational knowledge, and then get all the way down into the weeds. And COVID's impacted MIPS reporting just like it has just about everything else. So at the basic level, what is MIPS? Merit-based incentive payment system. It's a roll-up of 3 prior legacy processes, the PQRS, Physician Quality Reporting System, which actually started all the way back in 2007, not quite 29 years ago, as the PVRP, Physician Voluntary Reporting Program, and we've all been involved in it since then. Then there was a value-based payment modifier that's wrapped up into MIPS, and the Medicare EHR incentive process, which became meaningful use and now is called promoting interoperability, which most ED docs are exempt from. So who is required to participate? Which types of providers are potentially wrapped up in the MIPS process? Well, from an ED perspective, physicians, physician assistants, nurse practitioners, everybody that your typical claims go out under. So all of your providers typically are potentially eligible. Now, who is excluded? If you're new to Medicare, you're in an advanced alternative payment model, or importantly, you have less than $90,000 in Part B charges. So that's an important calculus to do at the individual provider level. Now let's look at eligibility status, and then let's look subsequently at participation. This is the most recent data available, looking specifically at emergency medicine, newly enrolled. Those docs and providers are exempt. 4% of emergency providers, newly enrolled, exempt. 0.5% in an APM, and 1/3, 33% of ED providers are exempt from MIPS specifically because they are below that low volume threshold. So in total, 38, almost 40%, almost 4 out of 10 docs are exempt from the MIPS program. So that should factor into your approach a little bit when you look at an ROI and how much significant effort the program might require. Now, what about participation? If you are eligible for the program and required to report, most folks do. So looking at emergency medicine, the most recent data available, 72,447 were MIPS eligible, and almost 71,000 actually participated, 97.6% participation. Doesn't mean they all did great, although I'll mention, in fact, emergency medicine does do quite well because of the specialized billing and coding processes that are common in the industry. So how do you know if you're in MIPS? There's an NPI lookup tool, and I've got the URL right at the bottom, And for the docs on the call, you might say, Mike, I'm not walking around with my NPI, but it is actually shockingly easy to obtain. You would Google your name followed by the 3 characters NPI, and your NPI is available and public facing, which sort of was shocking to me a couple of years ago when I found it out. Now, I'm a reimbursement guy, so we're going to talk about the money now related to MIPS and sort of weave our way through this infographic. So we've got the fee schedule that Mr. McKenzie and I talked about in the first lecture, 2021. $32.4085, $32.41 will be the payment per RVU. And then your merit-based incentive payment system score will adjust your conversion factor up or down. And the MIPS program lags 2 years from reporting to payment. So plus or minus 9% in 2023 for data that you report starting in January of 2021. And then if you happen to be in an alternative payment model, I think there are a couple of folks who normally attend this conference that are, and there is an APM that's already been developed by a very, very high-level working group within ACEP that's sitting on the secretary's desk. And this APM process, for other reasons, isn't really moving forward that quickly within HHS and within CMS. But that's the way the programs layer together. Now, an overview of the scoring process. You will end up with a MIPS total performance score, and we'll drill down into how that's calculated. And ultimately, that will adjust your conversion factor. Your conversion factor could go up, unfortunately, only a little. The highest level bonuses would be 0.5%, 1%, 1.5%. Might be neutral, you're held harmless, or might be negative. If you fail to report, there is a big stick, which would be minus 9% based on your 2021 data, subtracted from your conversion factor in 2023. There are 4 overall reporting categories: quality, improvement activities, promoting interoperability, which I mentioned most ED docs are exempt from, and cost. And MIPS is generally budget neutral, and that's bolded because it's going to play a big role in determining whether there are really bonuses available. And if you are a top performer in MIPS, all the way above 85 points, then there's a small additional bonus pool, $500 million per year, that ends in 2022. Small because it's spread over the entire House of Medicine that achieves that level. And historically, those bonuses really at the top of the program, 0.5%, 1%, 1.5%. And just so we have some basic math, if you're at the $90,000 in CMS allowed charges threshold where you qualify for the program, a 1% bonus would be $900. So MIPS scoring detail, we talked about sort of at the general level. Now we're going to peel the onion back a little bit more. So I mentioned that MIPS is budget neutral at almost all levels, and the bonuses are then derived from other groups' penalties. I mentioned the exceptional bonus, which kicks in at 85 points, and the penalty, minus 9%. So for sure, whatever we do, we want to avoid a penalty. And then, is it really worth all of the effort to march downfield and get a bonus? That's a group-specific decision, although, as I'll show, the bonuses are going to be pretty small. The MIPS program has become increasingly difficult to avoid a penalty over the years. Following the cursor here, 2017, 3 points to avoid a penalty, then 15, then 30, then 45, and now 60 points to avoid a penalty. So if we focus now on the right-hand bar in the infographic, 2021, we can see in the orange here, between 0 and 60 points for 2021, you get a penalty. Between 60 and 85 points, you're in the blue bar, you get a bonus. But the bonus in this area is derived from the penalties that are taking place down here. So if there aren't too many penalties, and we think there will not be significant penalties in 2021, even maybe beyond that, then there is not much money to redistribute into that budget neutral bonus pool. And then there's that extra $500 million pool if you achieve an exceptional bonus and get over 85 points. Economic impact of a MIPS penalty, again, the carrot is small, the stick very big. 2021 data, 2023 reporting, 60,000 visit ED, just following the items in bold here, $166,000 would be the penalty. And if you break that out for a typical fee-for-service group, 9% penalty, 60,000 visit group, 22% Medicare, common Medicare collection per visit, $140 a patient, $60,000 times 22% of the payer mix times $140 collection per visit times 9%, $166,320. 9 partners would be potentially common for a 60,000 visit ED, $18,480 loss per partner. So very meaningful. We definitely want to avoid a penalty. COVID has made things very tough for the House of Medicine, and CMS has actually recognized that. We need to look at the last 3 reporting years to give us a sense of what the forecast will look like for 2021 and whether in that blue bar between 60 and 85 points, there really will be much of a bonus. So COVID began ravaging the United States in March, right when the MIPS reporting was due for the prior year, right when the 2019 MIPS reporting was due. So CMS extended an olive branch and basically gave the entire House of Medicine a free pass on MIPS. Clinicians who have not submitted any data by April 30th of 2020 automatically, and that's very specific to that year, qualify for the extreme and uncontrolled circumstances policy and will receive a neutral payment, no penalty, for 2021, your 2021 conversion factor not going up or down at all based on 2019 MIPS reporting, because that MIPS reporting was due in March of 2020, right when COVID was really attacking the United States. So a very nice olive branch there, and gives us an insight into what things will look like if there are very, very small penalty dollars in that orange bar for 2021 between 0 and 60 points. 2020 COVID MIPS relief, it's not automatic, but you can apply for it. CMS has been, I think, very lenient in accepting applications. It's called the Extreme and Uncontrollable Circumstances Exception. May submit an application, and it's based on each category. Could be quality, cost improvement activities, promoting interoperability, or all 4. Quote, if you experience an extreme and uncontrollable circumstance such as, and then they call out the stuff that we're all living with right now, public health emergency, e.g. COVID-19 pandemic. Well, I don't think there's anybody on this call that is not experiencing a COVID-19 pandemic that prevents you from collecting data or that could impact your performance even on cost measures. And then if approved, those categories are removed from your scoring. So that's 2020. And for those who are unsure, well, should I ask for this exception or not, you actually have a little bit more time. It was published very recently that the deadline to declare this uncontrollable circumstance exception has been pushed out to February 1st of 2021. So you actually have a little bit more time. That's the bold font at the bottom of the slide, pushed out to February 1st, 2021. Now, what about this MIPS hardship exception for 2021, for this reporting year, for 2 weeks from now? Do I need to worry about my staff's mental health and who's got COVID? And how are we treating patients and my monoclonal antibody protocols? Or do I need to focus on MIPS? Well, hopefully we're taking care of COVID patients and MIPS is percolating through in the background, but maybe we need a little bit of a break, and Congress and HHS are extending that. This is out of the 2021 Quality Payment Final Rule FAQ, so just released in the last 10 days. Question: are there any policies to provide flexibility and to support clinicians during the COVID-19 pandemic for the 2021, when CMS says performance period, they mean your reporting period? Answer: we anticipate that the national public health emergency will continue into and through 2021. Therefore, we will continue to offer the application-based extreme and uncontrollable circumstance policy. So if you are going to struggle in 2021, or you are struggling, or you're struggling right now to set up your process, CMS is telegraphing that the hardship exception will be available. So how can we put this together? Well, bonuses have been very small for the last 3 years, and clearly 2021 is likely to be similar. So in the blue stars, you can see the bonuses. If you got the highest MIPS score in the country, you got a 100. 2017, 1.88%, 1.68%, 1.79%. Now let's look specifically at 2019. We mentioned previously that in 2019, you got an automatic exception if you didn't submit any data. So in the orange bar here, below 30 points, there were no penalties, 0%. This is CMS data. So what happened in the blue bar, which that year was between 31 and 75 points? There was no redistribution of penalty money into the bonus pool. The bonuses were zero unless you got into that exceptional area. And then again, these small bonuses, 0.5%, 1%, 1.5%. So let's put it together and predict what's going to happen for 2020 and 2021 reporting. So the year that we're in right now, what will that data generate? And next year, starting in just 2 weeks, what will 2021 generate? So 2020 reporting leads to 2022 bonuses. We stated in the beginning, the MIPS payment process lags 2 years. 2021 reporting leads to 2023 bonuses. And I've emphasized that MIPS is a budget neutral program. So we had very few penalties, actually none, in 2019. So the 2021 bonus was zero. We've got the hardship exception already for 2020 and 2021. So there will be very few 2020 and 2021 penalties. So the bonuses in 2022 and 2023 will be very small unless you eke over that exceptional threshold. And then again, 0.5%, 1%, 1.5%, and 1%, assuming you get just past the $90,000 threshold, $900. All right, now let's look at the inner workings of the program for 2021. 2021 category rates, quality is 40%, cost 20%, promoting interoperability, which we're typically exempt from, 25%, and improvement activities are 15%. For emergency medicine, there's usually a reweighting of promoting interoperability to quality, so that leaves quality of 65%. Let's look at the detail in each of these categories. It's only a 30-minute lecture, but let's try and peer in a little bit. Quality, you need to report 6 measures. You need 70% what's called data completion and 1 outcome or high priority measure. Improvement activities are over 100 options. I've got the link there to the CMS website. You need 2 high-weighted activities or 1 high-weighted and 2 medium-weighted or 4 medium-weighted activities. And for 2021, groups can attest that 50% of the clinicians participate in the activity for some continuous 90-day period. So it's not one doc, it's not all docs, it's 50% of the clinicians for any continuous 90-day period. Cost, that's category number 3. Medicare calculates based on their own internal administrative data. If you're interested in that, and it's a little bit out of our control, frankly, although we do a lot of advocacy work to try and make the cost category a little bit more realistic, you can go to the link there, MIPS/cost, and get lots of additional detail. And then promoting interoperability follows what I call the 75% rule. Hospital-based docs are exempt if 75% of an individual clinician's services are in a hospital-based setting. ED is a hospital-based setting, OBS, inpatient, hospital-based setting. And 75% of the clinicians within the group are determined to be hospital-based, and the whole group is determined to be hospital-based. So how do we get 60 points? Well, it's kind of all about quality for us. Quality is 65% because if you go to the right side of the slide, the promoting interoperability, you're typically exempt. Cost, CMS calculates on their own. There's not much you can do to influence the cost score. And improvement activities are binary. You do the improvement activities, you get your 15 points. So it's all about quality. What are the performance period? Quality you have to run for 12 months. So it seems pretty obvious that you might have a hardship exception related to quality. Cost is also 12 months. You might have significant impacts related to cost, that you can't have utilization review meetings because you're focused on COVID and your costs are going up. Improvement activities, just 90 days. So what's an alternate strategy? You could do nothing. So what happens if you do nothing? If your hospital has a hospital value-based purchasing score, since you are a hospital-based provider, you will be assigned that hospital's hospital value-based purchasing score. So which hospital am I assigned to? I work at five different hospitals within a multi-site group. Well, the individuals are tied to the hospital which they provide the service is to what's called the plurality, just the most Medicare patients. It's not the highest allowable or charges. It's literally like 412 patients at hospital A and 306 patients at hospital B, then it's hospital A. The group is tied to a hospital which a plurality of its facility-based clinicians are attributed. So that's the way you would march through the calculus. There's no election required for your hospital value-based purchasing score. It's automatically applied if it results in a more favorable score for quality and cost. Quality and cost. You still have to do the improvement activities. The hospital value-based score allows you as a facility-based clinician to have your MIPS process scored for quality and cost only. Now, what's the future of MIPS? And we're doing nicely on time. We've got MIPS value pathways, which is the next generation of MIPS. So right now, we pick these disparate processes. We pick quality measures. We pick improvement activities. Medicare assigns us cost. We opt out of promoting interoperability. And they're all disparate. The three different categories have nothing to do with each other. The concept between MIPS value pathways is that they would aggregate some sort of integrated set of clinical processes for all three categories. So Medicare has given us an example. It's down at the bottom. Let's use diabetes. So for a quality measure, hemoglobin A1C. How well controlled are your patient's hemoglobin A1C? This wouldn't be an ED measure. This would be for primary care. Improvement activities. We've got improvement activities related to glycemic management services and cost measures, total per capita cost. And then they get woven together and you get a single score related to your diabetes MIPS value pathway. And every couple of years, the federal government tries to reinvent the program. We had PVRP, PQRI, PQRS. MIPS was supposed to be a drastic departure from PQRS, but in truth, PQRS just became the quality category within MIPS. There was already a value modifier and meaningful use was already out there. So it's a little bit the same process getting reconfigured at times. And the thought was that MIPS value pathways would actually start rolling forward next year, January 1st of 2021. But because of COVID, they've held back a little bit. Quote, we have previously finalized that participation through MVPs would begin with the 2021 performance period. And we, CMS, recognize that stakeholders have been working hard to address COVID-19. Understatement. Therefore, we're not introducing MVPs into the program for 2021. And I can assure you that there's a very highly resourced group within ACEP working hard at the national level to develop MVPs for emergency medicine. We've had a number of meetings already. We've wireframed some ideas, and that's sort of marching forward in parallel with this program. Some strategy to optimize your MIPS performance. Well, 2021, I need 60 points to avoid a 9% penalty. So how do I do that? You do the improvement activities in the test, that gets me 15 points. You choose 6 quality measures you feel good about. You likely have chosen a QCDR, Quality Clinical Data Registry, or a regular registry. Regular registry is going to get tougher and tougher over time because the regular registry only has access to the CMS measures and they're shrinking a little bit. Check your scores with your vendor periodically. You can check your scores right now, still for 2020, and decide whether you feel like you've experienced a hardship and you should apply for the hardship exception. Consider a hospital value-based score or the hardship exception for 2020 or based on the realities that you face next calendar year for 2021. The deadline to submit 2020 data is March of 2021. Get ready to implement because this is starting January 1st. My contact information is here. As I've mentioned previously, I correspond with folks throughout the country on a regular basis. I just ask that you give a little bit of context. Hey, Mike, I was at Straight Talk, heard your MIPS lecture, and I have a follow-up question. Thanks very much. So we'll see what we have in the chat here. I'm looking. All right. Assuming that you are interpreting, but okay, this looks like Todd Thomas's chat, which was excellent. AMA, MDM, okay. So let me close that and see if there is any other chat. I don't see any other questions currently. Questions regarding MIPS 2021. I simplified it so much that it's now obvious to everybody.
Yeah, thank you, Mike. And I just, this would be a good time to kind of transition into our Q&A session here.
Perfect.
Just as a note that Dr. Gronowski has another meeting that he needs to be able to attend, so he may drop off early. So if anybody has any questions that are directed toward Dr. Gronowski, we can highlight them first while we still have you, and then we can move into some discussion on our other topics. So are there any questions for Dr. Gronowski? either on MIPS or ED reimbursement or final rule overview, we can cover those now.
I'm fair game. And if something occurs to you later, no problem. Feel free to just email me.
Can I jump in with a question here?
Hi, Sandra.
How are you?
Good. Nice to see you. I'd rather be
You too.
seeing you, but.
I know. Here we are. Hey, how do we know? Is there a way to know if we're being judged based on our own reporting, our quality improvement activities, or based on the hospital's VBP score? Is there going to be a way to tell how they've scored us?
Yeah. So if you submit data, then both are possibilities. So let's say you work through a qualified registry, then you submit data and you'll be scored both ways. And then 9 months after the year ends, the performance reports come out and you'll be able to tell retrospectively, but it takes quite some time.
Is there any way then to tell what the hospital's score was? So the QPP website is not telling me. I mean, it looks like it's scoring me based on our own reporting, but I'm just wondering if there's a way to tell what the hospital's VBP was.
Yeah, so it takes some digging, and it's not on the QPP website. So you actually have to research your hospital's total performance score, or VBP score. There's a couple of ways to navigate to that website. It's a clunky, sort of file to weave through. If you have trouble finding it, you can just email me. And if you give me the name of your hospital, I'll even try and highlight it a little bit.
Okay, thank you.
Sure.
All right, other questions for Dr. Gronowski? Just feel free to jump right in. All right, so there's no further questions for Dr. Gronowski. Thank you for your time.
Thank you.
Let's open it up then to discussion for, either to David McKenzie, Todd Thomas, Ed Gaines, any questions that we have for them. All right, we have a question here in the chat. Does anyone have any data on decreased revenue predictions due to auto insurance reform in Michigan, a percentage decrease in revenue predicted? So this, I believe, refers back to the Michigan auto insurance reform and the transition away from no-fault insurance. And if we have any projections on what that may do to our revenue predictions.
I do not know.
Yeah, I think it's going to be kind of, because insurers do have the option of, still getting a no-fault insurance, although they pay more for it. I think most people are probably going to go toward, a less expensive form of auto insurance. But I don't think we have any data yet on how that exactly is playing out, because that just started really this year. So I'm not aware of any, revenue predictions. I imagine it's going to be, a cut, but we don't really know how to quantify that just yet. All right, I have a question for you, Ed, just on your discussion earlier on the federal level of balanced billing. So in your opinion, if this bipartisan deal that's currently out there ends up getting enacted into law and ends up passing as is, do you see or do you feel that that there will be any additional appetite for this on the national level, or is this essentially going to be a done deal for a while? Meaning if we're not really perfectly happy with some of the parts, or if there ends up being some unintended consequences, do you feel that this is something that we could continue to attack on the federal level?
Yeah, it's a good question, Dr. Gratz. And I think, number one, everybody is sick of this issue. And those of us in emergency medicine, as Mike and David know, we've been toiling in this field for 10 plus years, longer than just about anybody. with California's decision in the Prospect case, which was about 10 years ago. And then New York came online in 2014, effective in 2015. So we've been very active in this area, but and I think there's a lot of fatigue at the legislator and staff level on this issue. If you go back and look at what happened in April with the Energy and Commerce hearings and the Health Committee hearings, the plans thought they had that bill essentially lined up for passage. And we came back as clinicians and supporters a couple of times and defeated their efforts. And I think it was a little surprising to them because the House of Medicine was very unified on it. And the hospitals were generally supportive, which has not always been the case in matters of lobbying and legislation. That said, there is allowance in the law for both HHS and the GAO to do studies about the impact. And those studies could impact further legislative tweaks. But I think if this bill passes, we're probably stuck with it for the next few years until we get something from either GAO or HHS that really startles members of Congress into believing that they've got to do something. I personally believe it will be very harmful to small to medium-sized groups. I think it will force additional consolidation, which is probably exactly what some of the drafters do not want. And I think if you consider the scenario that I went through, a private, small, Democratic group, say 2, 3, 4 hospitals, how many IDRs can they do in a year under the limitations? And I don't know if I made this clear, but there's a big question whether or not you can batch claims by TIN or you have to batch claims at the individual clinician level. If it's at the individual clinician level, it's effectively very limited IDR. And as I mentioned, the statistics from Texas, emergency physicians filing over 27,000 IDRs in the first 10 months. Emergency medicine is winning in areas where we have accessible, meaningful IDR. And the plans know that. The plans already have signaled that they want to pull the Texas law out. And they don't want that to be a national standard. So I think we'll know in 48 to 72 hours if this is going to happen. It sounds like they're going to bifurcate the COVID relief packages into that which they can agree on right now, and then that which is controversial. And SMB would certainly be in the category of that which is controversial, in addition to liability protection and state and local government relief. So I think that might help us because it gives us a little bit more time. Clearly, they tried to ram this thing through announcing it Friday night with the hopes that we heard from Leader McConnell's office that any changes in this law had to be done by yesterday afternoon. So we literally had from Friday night at 5:30 until 2 or 3 o'clock yesterday, Monday afternoon, to make any kind of request for changes on a 400-page bill. So that tells you a lot about the other side. They're saying they hate this bill because it's a gift to private equity and physician groups. I have to laugh at that.
Nice spin.
Right. I think I posted on Twitter over the weekend the quote from Shakespeare's Hamlet: "My lady doth protest too much, methinks." And I believe that that's what they're doing here. They got a lot more than they wanted. This 90-day cooling off period will really reduce the number of IDRs that are filed. And if it has to be by individual clinician, it'll further reduce it. So essentially what we're ended up with is not unlike, unfortunately, what Michigan has, which is a benchmarking bill. And if you step back from the bigger policy perspective, this is a really long answer to your question. If you step back from a policy perspective, you say, okay, benchmarking. What's the difference between benchmarking and Medicare for all, right? Part of my argument to the insurance companies is you want to benchmark payments. Well, isn't that really Medicare for all? and do emergency physicians, if they got Medicare for every patient, would they be better off or worse off? I don't know. I don't know the answer to that, but it's an interesting question. And I think if this is successful, the unintended consequences, a lot of doctors will say, hey, okay, if this is the new world, we'll go for Medicare for all, because why am I fighting it out over commercial insurance, right? Why do I want to create this whole infrastructure to file IDRs? I'll stop now. I'll get off my soapbox.
Well, thank you for the response, Ed. And I think certainly too, that's an angle I haven't really thought about it from before, but with essentially benchmarking, you're really reducing any sort of type of market competition, which is right. The whole idea of why the current system would be beneficial, compared to Medicare for all, whether, and however you see that argument. So that's really a good point. Maybe new talking points to potentially keep in our holsters when talking to our politicians that may be considering these types of bills on the state level if you don't already have something that's in place.
And against the backdrop of United Healthcare's Q2 profit in 2020, which was $7.2 billion. If you take 20 business days in a 90-day period and you divide 20 business days into 7.2 billion, you come up with $115 million a day in net profit per business day. That's net profit. That's not EBITDA, that's net. Ooh. While you're being called a hero and you're being thanked by everyone, you have this backdrop of the health plans literally printing money. And this will print even more money to them. I mean, look at what's happened in California, benchmarked to 125% of Medicare. Look what's happened in Illinois, no accessible IDR. Look what's happened in New Jersey. Those states have inaccessible and unmeaningful IDR, and there is no dispute process, and they eventually have a benchmark. So, we don't have to, there's data out there to show you what the wrong way to go is. And unfortunately, I think that's where this law ultimately ends if it gets passed. ACEP has filed a letter today objecting to several aspects: the 90-day cooling off period, the fact that Medicare and Medicaid are not excluded factors in IDR, and several other important provisions. So I think that's important.
Yeah,
and is there opportunity to?
Just today, while we were on this call, Laura Wooster shared the ACEP summary of the act as well as the letter that they've submitted. So for those of you that aren't subscribed to ACEP Engage to the ACEP website, I would certainly encourage you to do so, because there's up to the minute information released through that resource.
And is there an opportunity to influence the regulatory guidance?
Yeah, David, I think that's, if the bill passes, that's where we've got to really focus all of our energy, because, and you'll remember when the ACA passed in March of 2020 or 2010, this is the proverbial three horsemen of the apocalypse, three different agencies: HHS, Department of Treasury, and Department of Labor, because you have ERISA plans and ACA plans. So the concern is, because it's the three tripart agency effort, that the folks at CCIO, the same CCIO that we dealt with for as you know, for many years, would be the ones who would issue regulations. And CCIO has tended to take a very pro-insurance kind of tact, at least as it related to the greatest of three and the issues that we saw in the ACA. So, but you can clearly, in a lot of these states, you can win the legislative battle and lose the regulations, or vice versa, because I didn't count the number of times, but I know at one point we counted the number of times that the ACA used the term "the secretary shall." There were hundreds of times in this bill where they referenced the secretary shall. So clearly they're giving the secretary a lot of a lot of voice. I think one of the arguments we would make for example, for batching is it makes no sense to say that batching has to be done at the individual clinician level. We should be able to do it at the TIN level. That seems to me to be a regulatory decision by an HHS as opposed to having to go back to Congress and say, can you please say in the bill that physicians that are under 110 can batch claims? Yeah, so I think that's where we make some headway.
Thank you. There's a question here in the chat from Dr. Michener is what's the payer mix on average for EDs currently? And that it had been mentioned that 22% is for Medicare, but what about the others? And if you guys have any data on what the current national payer mix looks like.
We get that information from the CDC, usually lags a couple of years. The last one, and anybody remembers differently, jump in, but it's about 40% Medicaid now, or self-pay. Medicare is usually somewhere between 15 and 22%, and commercial is typically around 30%. Depending on where you are, your payer mix could be different. Your commercial plans may or may not be in managed plans as well. But that's kind of the way it breaks down, with a growth over the last 20 years of Medicaid, especially with the Medicaid expansion.
Yeah, and then it looks like Dr. Zach Giroux placed a photo that you can download and look at in the comments, with the comment that, you know, there does seem to be some variability from hospital system to hospital system. This particular screenshot looks specifically at some of the major for-profit healthcare systems and just seeing some of the varieties that exist within that. So, you know, certainly it's probably, you know, got to take a look and see what your local data is, you know, if you're making any sort of meaningful decisions based on that. All right, do we have any other additional questions?
Is it snowing in Michigan?
I can't speak to Michigan, but I've been doing Straight Talk since 2003, and it has snowed every year. And in the last 15 minutes, it has started snowing like crazy outside my window. So it's kind of like Jaws 4, where they moved to the Bahamas and the sharks still found them. So even though I'm not in Michigan, the snow has come for me.
Must be you're keeping it all, because we're in Michigan. There's no snow on the ground even, or anything coming down at the moment.
Now I did hear
it's super sunny.
Last year when I was in Egypt, that it didn't snow at Straight Talk. Is that correct?
Last year, I think it did snow. It started snowing.
I think it did.
Yeah, I think it did.
Yeah.
That's always my excuse to stop early is, well, you know what? It's starting to snow, so I'm going to let you guys go home early.
Yeah.
Some years when the speakers can see out the window and just this raging blizzard, and we're kind